Hey everyone, welcome to the second of our two-part series on RADV. In our first episode, we looked at what RADV is and how to build an audit-ready operation to address it. Now it's time to focus on the frontline role of providers and how the right technology and collaboration can make accurate, defensible documentation part of everyday care. If you're just joining us, my name is Mark McKeown. I'm Vice President of Sales and Business Development for InfoScience. And joining me again is Colleen Gianatasio. Her 20-some years worth of experience in risk adjustment, coding education, and value-based care from both the preparer and the provider side make her a perfect contributor to today's topic. Welcome, Colleen, and glad to have you with us again.
Thanks, Mark. It's good to be back.
One of the things before we get started is, RADV risk has always seemed to be a payer side problem. But you have to remember that, I don't know you know this, but providers actually control the data input. It's what happens at the point of care, not after it's all over and go back and correct it. That's important. So provider-first technology can actually bridge that gap between compliance demands and clinical reality. So let's start from that. So why do payers matter? Why is provider documentation the foundation for RADV compliance?
Well, Mark, let's start with the original purpose of a medical record. The medical record was intended as a way to share the patient's medical story, and it serves as a way to provide continuity of care if that patient is seen by another provider. Providers rely on the documentation in a patient's chart to communicate important patient information. So incorrect documentation can lead to gaps in care, and even worse, dangerous patient outcomes. Accurate documentation supports compliance with federal and state laws, and it also helps us to reduce fraud, waste, and abuse in the healthcare system. Codes are driven through documentation. Without great documentation, we can't do great coding. Documentation is missing something, accurate codes cannot be assigned. I'm going to say this very slowly. Documentation will make or break your RADV success. Documentation will make or break your RADV success. I always advise providers that they can miss the code, right? Because providers in most cases are not coders. You can miss the code, but if they can give us the documentation, we as professional coders can help you and send the correct code. Without the documentation, we're not able to help you with that.
That's a good way to start. What have you found are some of the biggest barriers that clinicians face in consistently documenting at the level that's required for a RADV audit?
There's three. The first one, the biggest one, is there is no time. Clinicians are still seeing patients every 15 to 25 minutes every day. There's simply not enough time for them to take care of the patient and meet all the administrative and documentation requirements that are being put on their shoulders right now. The second is that the rules are very complex. And to go beyond that, they're constantly changing. ICD-10 rules are updated every year. Now, in the past few years, they're being updated twice a year. There's additional CMS guidance. There's coding clinic guidance that comes out quarterly. So it really takes a business of healthcare professional and certified coders to remove these barriers. And number three, coding guidelines do not always align with clinical guidance. And I'll give you an example of that just to bring the point home. Coding guidelines very specifically tell us that if a patient has diabetes and they also have a cataract, according to ICD-10 coding guidelines, we can make the assumption that those two conditions are connected. They're related. Well, I've spoken to hundreds of physicians who disagree with that, and they say clinically that doesn't make sense to us. Another example would be we have very explicit guidelines around coding for cancer, and that if a patient has no evidence of disease and there's no active treatment in that encounter, coding guidelines are extremely explicit, and they tell us that should be coded with a history of cancer code. Providers looking at it clinically will say that a patient who has cancer will always have cancer, and these are the three top barriers to RADV success.
Interesting. Makes it tough for them, I know. You've spent quite a bit of time dealing with providers as well. So when you do engage providers, What is the best way so that they can see RADV as part of good care and not just another administrative burden that's put on them by the insurance company or by the federal government?
Yeah, a few years ago, I made a decision to make a radical change in the way that we speak in our organizations and to our providers about risk adjustment. I made a concerted effort to make it about patient care and make it more patient-centered language. And I'll give you some examples of that. So instead of using the term RAF, risk adjustment factor, right? Oh, we're looking at your RAF score and it's lower or higher than your peers. That really has nothing to do with patient care. So for those providers who don't see the value of risk adjustment, change the way you speak. Don't use RAF. It has nothing to do with clinical care. Instead, use severity of illness, because then it brings it back to the patient. Which of your patients have a higher severity of illness compared to their peers? Same thing can be done with HCC. We very frequently use the jargon HCC when we're talking to providers or other clinicians. Instead of using HCC, make it patient-centered, make it around what they're trying to accomplish, and HCC replace that with chronic conditions. I think this has been a really effective way to make sure that we're really pursuing what the intention of risk adjustment is, and that's better patient care.
Awesome. Awesome. Good points. Good points. As we get into enablers, as the industry tries to provide solutions to the payer as well as to the provider, what does it look like when AI-driven coding support is fully embedded in an EHR workflow?
This is some of the most exciting new advancements I've seen. And to me, it takes us beyond a code capture exercise, and it truly allows us to support patient care. Here, I'm recommending when you're implementing something like this that you create work groups. And these work groups are going to focus on implementing new coding updates as they come out and get them into our system so that you can quickly respond to the new guidance that I mentioned before, whether it's ICD-10 guideline updates, coding clinic updates, new CMS guidance. Having these work groups in place in advance really helps enable us at the point of care. Then we can also support you on the back end. You want to make sure that you're providing careful monitoring and auditing along with feedback loops for continuous improvement. So don't just turn it on and say, okay, we've implemented this new solution and it's wonderful. You want to monitor and audit it just like you would your human team. A very important thing to consider is feedback loops so that you're providing continuous improvement.
Awesome. Awesome. Good points. Good points. You had mentioned at our last session, as well as alluded to it a couple times, about the noise when it comes around to everything going on in the industry and coding and whatever. How can technology reduce this type of noise and only surface high quality, actionable suggestions?
That's a great question. So we have to remember that this has been a long journey from fee for service to value-based care. And right now there's a lot of spotlight on value-based care. But most EMRs were built in a fee for service world. Most EMRs that we're using were created well over 20 years ago. So the EMRs are set up for fee for service to capture CPT and HCPCS codes. They weren't necessarily set up optimally to capture diagnosis code. So the recent pushes for increased risk adjustment factor scores has added to the problem. And I've seen, I think we said this in the last segment, I've seen where groups are trying to do too much too quickly. So they're giving little bits of information and putting quick fixes in place. And sometimes that adds to the problem. So a real high quality solution is going to allow providers to tell us what they know. And it gives us an opportunity to offer true clinical decision-making support at the point of care.
Good point. Good point. Can you share an example of where you think technology significantly improved the documentation completeness and especially for our conversations right now, audit defensibility?
Yeah, I can give you lots of examples. So I think one of the most impressive solutions I've seen in the past 5 years is being able to provide queries at the point of care. that's helped the provider tell us that patient's story. Instead of using that retrospective approach where we do an audit from charts from a year ago and then we tell the provider what they did wrong and how they can improve, it's slow feedback. And slow feedback is no feedback in a lot of people's opinion, right? Okay, I did that last year. I'm not going to remember to change it. But if we bring it to the point of care, then we're changing that behavior in real time. Taking away provider abrasion, which I'm always really aware of, this new technology can like reduce clicks. We've all talked to providers who count the number of clicks it takes them to do accurate coding and reporting. I'm going to share 2 examples with you that I received this feedback from providers that I was working with. The first one is the provider was expressing frustration in not being able to provide specificity around coding for chronic kidney disease, which is really important when we're talking about value-based care and telling the accurate severity of illness of patients. Because the EMR she was using, again, was outdated, she couldn't find CKD3. And she said, to be honest with you, if I can't find it in the first 30 seconds, I'm just going to pick unspecified. Well, that doesn't serve good patient care. It doesn't serve risk adjustment purposes. But updating that technology and offering them a more up-to-date technology solution quickly solved for that. The second one is it allows us to make the most of the time that the patient, the provider has with the patient. Like I said, they're still spending 15 to maybe 25 minutes with a patient. They don't have time to do the incredible amount of detailed work to review the patient's chart for everything that's important to tell in that patient's story. And one of the examples I got from a provider when we were using some technology to help support clinical decisions at the point of care is they were able to provide lab results for hyperparathyroidism and give those PTH lab results and where they were found and provide it to the provider while the patient was in front of them. And the provider came back and said, this was so helpful. I would never have had the time to go back and look for those, so I would have missed it. So those are 2 perfect examples.
That's great. I know our founder is a practicing physician as well, and he says all the time, prior to some of the systems as he's implemented, is the number of hours, literally hours, they spend on their own time, whether it's dinner time, after the kids go to bed, or whenever, doing documentation. And unfortunately, the further removed the documentation is from the point of service, the more likely it is to be a little less specific as it may be. So you're absolutely right. Being able to get this at the doctor, at the point of care, and as quickly as possible, anything that could make it easier for them and more accurate is certainly an advantage to them.
I agree. And I think the term pajama time is used very frequently in my area. And I think it's a sad reflection of our healthcare industry that our busy clinicians not only see patients every 15 to 25 minutes, but they have a term like pajama time where they are documenting, after they've had dinner and put the kids to bed, and now they're documenting to meet their requirements of their job.
Exactly. But I hadn't heard that, but that's interesting. Pajama time. I'll use that one again. Talking of building a culture for accuracy, how do you think plans and providers create feedback loops that can reinforce good documentation habits?
Okay, I've got lots of ideas here. So one best practice is to share both overcoding and undercoding opportunities. I think when we're auditing, we want to make sure, especially in RAD V, don't overcode. We want everything to be supported, but overcoding definitely puts us at a RAD V risk. But we have to remember that undercoding results in insufficient reimbursement for anticipated costs, and that's a problem as well. It's another area where we can do better is to share best practices. We all have worked with a group of providers where one provider does things a little bit better than the rest. Well, share those best practices. It's a good time to celebrate providers who are doing a great job. Too often, I think we focus on what they got wrong and what they left on the table and what they could have done better. Let's take a moment to catch them doing something right and share that across the board. Another piece of advice is to give them small bites of information. For those of us who've been in the industry a long time, especially those passionate coders and business of healthcare professionals, we speak this language. We can quote guidelines and policies and procedures, but it's a lot to digest if you're not doing it every day. So give them small bites of information and be thoughtful around how many queries that you're sending on any given encounter. Going beyond that, when providers are resistant or disengaged, because we've all run into those providers that just feel overwhelmed with this process, and they're going to express that, and they're going to be very vocal about it. Don't walk away from that. Don't think that they're being difficult. Find out why, because those providers are usually the source of really getting to the root of some of these key issues. And then lastly on this topic, make sure to include your specialist. Most specialists are approved providers for risk adjustment purposes. And in most cases, when you look at who the health plan is educating, the education is only given to PCPs. So consider adding cardiology, nephrology, and behavioral health to your education and engagement efforts.
Great point. That's a great point. And finally, what do you feel is the long-term impact when we can get providers and plans to collaborate effectively on documentation integrity?
Okay, there's a few. First is less provider abrasion and less burnout. We need our providers to stay in practice. When we have less provider abrasion, they can spend more time doing what they went to medical school for, and that's taking care of the patient. And when a provider's head does not have to be buried in their EMR while they're taking care of the patient, it can lead to increased patient satisfaction scores because they can engage more closely with the patient. That indirectly can impact plan stars and HEDIS scores. And lastly, what we're all trying to accomplish, and most importantly, better patient care.
Excellent. Excellent. And Colleen, I think that is a great way to end. I would like to thank you for your time. So folks, this kind of wraps up our RAD V Miniseries, but the work of audit readiness really never stops. By engaging your providers, enabling them with the right type of tools and software, and building a culture of accuracy, plans and providers can face RAD V with confidence and face that challenge and get through it. So thank you again for joining us. If this series gave you any new ideas to strengthen your documentation and compliance, please share it with your network. And as always, let's keep decoding care together. Thank you for joining us. We'll see you next time.